Welcome to this explainer designed specifically for healthcare executives and policymakers. Today, we're going to deconstruct a real game changer in public health measurement, the HLS-EU-Q47. If you're looking to design smarter interventions, allocate resources more effectively, and ultimately reduce systemic healthcare costs, well, understanding how to accurately measure your population's health literacy is absolutely step one. To get you those actionable insights, we'll quickly walk through the framework's architecture, its cognitive processing dimensions, the actual math behind the scoring, and most importantly, how you can apply this to your strategic policy decisions. Let's jump right in with the origins and architecture of this framework. So, where did this tool come from? It was actually developed through a major collaborative effort by a consortium of 8 European nations. At its core, the instrument uses 47 highly strategic questions to evaluate how people interact with critical health information. And the beauty of it is its scalability. It works just as well for an individual clinical diagnostic as it does for macro-level population metrics, allowing you to standardize and benchmark health literacy across incredibly diverse demographics. Next up, we need to look at the information processing dimensions, or what we call the cognitive pipeline. Before we can look at the data, we have to understand how this tool maps the human brain's progression of processing health data. It evaluates a very specific 4-step pipeline. First, access. Can a person even find the right medical information? Second, understand. Can they comprehend what that clinical jargon actually means? Third, appraise. Do they have the ability to judge if the source is reliable? And finally, apply. Can they take all that and use it to make an informed, healthy decision? Now, let's see how those cognitive steps intersect with the real world to build the 12-dimension matrix. This is the true engine of the HLS-EU-Q47. We take those 4 cognitive processes we just talked about and we map them horizontally across 3 major domains in the continuum of care: healthcare, disease prevention, and health promotion. This creates a really elegant 3x4 matrix yielding 12 specific subindices. Those 47 questions we mentioned earlier, they are distributed perfectly across these cells. This gives executives a pinpoint diagnosis of exactly where a population is succeeding and precisely where they are falling through the cracks. Moving on to the scoring formula and criteria. How do we turn this survey data into standardized metrics? Qualitative survey responses are great, but as leaders, we need hard data. When respondents take this survey, they rate the difficulty of various health tasks on a 1 to 4 scale, where 1 is very difficult and 4 is very easy. This subjective feedback is then run through a specific formula. You take the mean score, subtract 1, multiply that by 50, and divide by 3. It might sound a bit academic, but this calculation is absolutely crucial for transforming human experience into a rigorous health literacy index. And why that specific calculation? Because it normalizes all survey results to a maximum achievable score of exactly 50 points. Clean, simple, and standardized. For your actual policy planning, you're going to want to focus heavily on these strategic cutoff points. A score from 0 to 25 categorizes a population's literacy as inadequate. Anything greater than 25 up to 42 is flagged as likely problematic. And a score over 42, up to that maximum of 50, is considered likely sufficient. These thresholds serve as your immediate dashboard for assessing public health risks. Finally, let's talk about executive policy application and how you can use this to drive evidence-based action. When you look at the macro-level data gathered across Europe, you'll see that population scores statistically follow a perfect normal bell curve distribution. For a policymaker, this is a massive validation. It proves that the instrument is highly reliable for large-scale macroeconomic health planning. Because health literacy distributes predictably across different countries and cultures, you can trust that the HLS-EU-Q47 provides a scientifically sound foundation for your resource allocation. So, by identifying specific cognitive deficits within the continuum of care, rather than just relying on broad guesswork, you can stop wasting budgets on generalized public awareness campaigns. I want to leave you with this final thought. If you know precisely whether your population is struggling to understand health warnings, or if they're actually struggling to apply disease prevention advice in their daily lives, how will you utilize these exact metrics to design their next highly targeted, evidence-based intervention? Thank you for joining this explainer.